The Christian Health Association of Kenya is a national faith-based organization of the Protestant churches, health facilities, and health programs from all over the country. It brings together various denominations and their health institutions, from the teaching and referral hospitals to colleges of training health workers like nurses, to community-based healthcare programs. Our main mission is to continue the healing ministry of Christ, just providing compassionate, quality health services to the people who most need it as an expression of the ministry of the church. Currently, we have over 540 members. Amongst these, we have 22 hospitals, about 53 health centers. Majority of the rest are dispensaries and some community-based healthcare programs. But in addition, we have 13 colleges providing training for middle-level health workers. Maternal health and child health is a key priority globally and in our countries. And is one of those Millennium Development Goals many developing countries are struggling with. And as health workers, we know a family and a woman having the right timing, having the right spacing, having the right number of children that she or they can be able to adequately support as an impact on the health of the child and the woman and the family. Then we have people who have other health challenges, which make them even a lot more vulnerable to complications related to pregnancy and childbirth. So we understand that each individual may have what is optimal in terms of what they can have and so on. Then depending on what method of delivery and what complications have been experienced when one is delivering, we know that subsequent deliveries have to be properly timed, properly managed, and well assisted by a well-equipped health facility and health workers to ensure safety of both the mother and the outcome, good outcome of the pregnancy. First and foremost, I think to clarify, sometimes we've had misconceptions about religious and faith-based institutions and leaderships, positions and perceptions about family planning. I think we like to make it very clear about our perspective of what family planning is. It's about empowering women and families and their husbands and their spouses and their families to make their choice, the most appropriate choice in terms of timing of the pregnancy, about spacing that is healthy, about the number that is both healthy for the woman and for the child, but also that as a family they're able to adequately support, through the developmental stages of a child up to the time they're educated and so on. So with that common understanding, ideally, would appeal to the church, both within our countries and outside, that we have a shared understanding about what family planning is about, and then appreciate why it's important, because it's considered one of the best strategies in improving maternal health and child health, particularly neonatal newborn health. That by assuring the health of the woman, by assuring the health, we're able to improve the health and ensure healthy delivery, healthy child that is born, and then a family that's able to adequately cater and support for their children. Our membership is quite diverse, so depending on what member institution you're talking about, the scope of the service can be quite varied. The Protestant churches generally embrace family planning, both artificial and natural methods. So the hospitals will provide a full range, from short-term methods to long-term, including permanent contraceptive methods. As you get new capacity within a health facility, they identify services that they could add to the list of what is already provided. And particularly when you have health workers that know the value of a service like family planning and the benefit, they can actually recommend to management to establish service. However, one limitation to this is where the owners of the facility, say a faith-based organization, a particular church, or if it's a private sector facility, have certain restrictions about the scope of service they can offer. So church may say, we don't want to offer any artificial methods. So if that's their choice, then as a health worker, you can demand, I must provide it. You can provide information to the clients that you think would benefit from it and advise them or refer them to an alternative provider within the neighborhood who would be able to provide that service. Family planning is an English terminology, so communities will use whatever terminology comes close. I think the key thing is, I think key message will be about spacing children. What probably may not be a very popular terminology is this of stopping childbirth. I think those are not, African traditional communities would not be a very easily used terminology. But in terms of spacing childbirth, that they will describe it in their own way, and those discussions actually do take place, particularly amongst women who really bear the greatest burden in unwanted pregnancies. But it varies from community to community. Our member health facilities and programs do provide various reproductive health and family planning services as guided by the national policy. Kenya has a policy on reproductive health and also on family planning, and even guidelines on how to communicate about various methods and how to deliver them. So the health facilities do provide those services. There's no resistance. Generally, the national policy is that government provides immunizations free of charge, family planning commodities free of charge to both public and faith-based health facilities. That's the policy commitment. However, the reality on the ground is that even though policy provides for a wide range of choice of family planning methods, there is often a challenge of availability of all options. You may have some, you may have a few, but oftentimes you don't have all the options. The ideal situation is where at every service outlet you have adequate communication tools, IEC materials that help you to educate women and families to make their own choice, informed choice about what method they wish to pick. But the challenge becomes, no, they're not available. The second aspect is where the reality is that some methods cannot be provided at certain levels of healthcare. If it's at community level, you cannot provide surgical methods or methods that require a bit more invasive procedure, like intrauterine contraceptive devices. So you probably talk about the appropriate level. Do we have the appropriate methods for the appropriate level of service? And what I would say is that there's good effort to make them available, but due to challenges of either inadequate of funding or some weaknesses in the logistics supply system or the weaknesses in information system, kind of trying to manage the demand, to match the demand with the supply, we have challenges of having access to adequate supplies. Generally, the healthcare system has a defined referral steps. If you're at community level, you know I need to refer to what we call a dispensary. A dispensary is supposed to refer to a health center to a hospital, and a level 4 hospital to probably a referral hospital. However, the reality is that sometimes there are areas, in rural areas, where the facilities are too far apart, so that it's easier to talk about where it should be referred, but it's a different reality, whether it's feasible for a woman or a person needing that service to actually be able to access the next level of service. Sometimes also you are nearer the hospital than the dispensary or the health center, so people will go directly to that higher level of service delivery. So particularly as regards family planning, if people know where I should refer for the next scope of service that I'm not able to do, but sometimes the reality of getting that functional is what is a challenge. And then, of course, as I've already mentioned, the fact that supplies or choices may not always be available. You can be referred to that other next level, but even the options you wanted, you find that they cannot be offered at that particular point in time. Within communities, acceptance to any service depends on how adequate the information is, what they feel about potential risks, and if they have had any contradictory information. Sometimes there are cultural myths and misconceptions about a service. So the barriers that we often find is where there have been cultural misconceptions, or where we are dealing with women who have not had much access to formal education or even access to basic information about reproductive health and family planning. So those are best addressed through appropriate communication, education, and empowering them to be able to make their own choice. Well, the choice about family planning is to empower women and families in general to make or to be able to achieve the desired spacing, timing, and number of children they wish to have. So when they're not able to have the method they best prefer or that is best recommended, then either they end up with a method that is not very, very suitable, or that's not very convenient. Maybe they wanted a longer term method, they get a shorter term, so they need more frequent visits for subsequent methods. Or, it reduces their interest and motivation to keep using the family planning method. And that, of course, may have the impact of having an unwanted or ill-timed pregnancies. There's a lot of desire to, expand the scale of or scope of services provided, increase access, reach out more women and families, have all methods available, assure quality. Now all of these create the needs for training and capacity building of health workers to keep updating their skills, knowledge and skills in family planning service provision. We have need for more health workers in a faith-based situation, particularly in Kenya, where we have to also finance the cost of health workers, pay their salaries and benefits with resources that we generate from service delivery. We are constrained by the number of health workers we can have. So we need more health workers. We need training on a continuous basis, upgrading skills. We need financial resources, particularly to support logistics to enable health facilities to go out, to reach out to families where they are. We strongly believe that family planning should not be a service provided in a hospital or health facility only, because people are not sick. People need to be empowered, to have this service. Is a preventive, health promoting service. So we strongly recommend being able to reach out, outreach services, go closer to the homes, take the message out there, provide information, create demand, and provide some services there, and then refer to the health facility for those that require a hospital setting. So we need finances for that. We need to improve our information system so that we can document more, document better, be able to plan well in terms of the commodities demand and match that with the supply system. So the health information system is the other area. And then, community mobilization. We need a lot of continuous information provision on the value and benefits of family planning, on the options, addressing some of the myths and misconceptions. So the whole area of information and communication. Support us to be able to expand and the scale of what we are doing in family planning services. Help us to have a more integrated approach to reproductive health. Help us to address some of the barriers, some of the gaps, to enable us deliver a better quality service. Then the other appeal I would make is, we engage in consultation to build consensus on our messaging around family planning. I think one of the gaps that we have is how we can engage the religious infrastructure, the religious structures. We have churches, we have national structures, regional structures, parish level, congregations, communities, women's groups, youth groups, men's groups. Then we have the clergy, and we have the lay leaders. It's a rich opportunity in terms of messaging and empowering behavior change. So we need an approach that we have health workers as resource people work with the religious leaders and the leaders within faith communities to be able to come up with consistent messaging that is appropriate and that addresses the best interest of the woman, of the child, of the family, and avoid getting involved in a lot of or stuck in controversies and different messaging around why and what in family planning. An unintended pregnancy means that they were not prepared for it. So a couple of things for the unborn child. Either the health of the mother is not good enough, both physical or mental, psychological, or nutrition-wise, and therefore you can end up with a child developing complications or being born with complications. Secondly, it could be that the mother's state of health is such that she deteriorates within the course of that pregnancy, and it could have harmful effects, either further complications, or even sometimes lead to mortality or death of the mother. The other implication is that a mother carries a pregnancy psychologically. She's so traumatized because she's not ready and prepared for it, and therefore that affects her mental health. But while the child, as regards the child itself, you have a child or children born when they are not expected, or maybe the family was not ready, and they come to an environment where there isn't enough or adequate care or support extended. So the child grows with difficulties. Either they are too many close together, they need food which they can't get adequate, they need health care, they need schooling, they need things that the family is not able to provide. Mm-hmm. So that also affects the growth of the child, and subsequently the opportunities that that child could otherwise have had if they got good upbringing, good education for their future. Sometimes we've had initiatives of non-governmental organizations and community-based organizations that are providing information about health and well-being, and making information about family planning also available out there in the community. And usually when you are addressing the demand side, they are told those services are available at the health facility. So when you have people coming to the health facility asking for a service, then that creates the need to get that service going. So it may be demand-driven, and also the demand can also make the health facility maybe improve or expand or introduce new aspects of the service that they are not providing. There could be, suddenly there's a demand for permanent methods, which before were not considered necessary in that community. So then that makes a health facility consider how to begin providing those services. The Christian Health Association of Kenya and our network of health facilities, we do embrace partnerships, and partnerships with various stakeholders. We have partnerships with communities that we serve by engaging with them, receiving feedback from them, trying to provide the services that they best need. We have a strong partnership with government, the Ministry of Health, because it's the regulator, it develops policy, it provides essential commodities and support. We partner with other faith communities, religious organizations, and sister churches abroad and so on. But we also partner with non-governmental organizations, both national and international, in various aspects of health. There are those who are in capacity building. There are those who are in health system strengthening. There are those who have projects to promote reproductive health and family planning. There are those who have been contracted to support the distribution of supplies. So we have an open door policy. We do partner